Good afternoon, doctors. On behalf of Vitro Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, as you know, at Hetero, we market products in different therapy areas like in gynecology, orthopedics, derma, respiratory, etc. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. We have 30 years of excellence and 300 plus products and presence in more than 125 countries. Recently, we have introduced Carbetocin. Carbetocin, as we know, is used for prophylactic management of PPH. PPH is a condition which can lead to disaster, which has the potential to lead to disaster. While there are several papers and guidelines which suggest the use of Carbetocin, it's marketed in several international countries. We have eminent speakers to give insights on their experience with Carbetocin. Today, we have Dr. Devika Chopra with us to give her insights on Carbetocin. Dr. Devika Chopra is MBBS, DNB, MSc from Oxford, UK, MN AMS, ICOG. Madam is consultant at Bhatia Hospital, Wokhard Hospital, St. Elizabeth Hospital, SRCC Hospital, Ruxmani Hospital, and her own clinic, Hope Clinic, Tamil. Madam has several publications to her credit, just to name a few. Anti-NMDA receptor antibody encephalitis in practical endoscopy. Oocyte retrieval in textbook, The Art and Science of ART. Management of menopausal symptoms, book for medical officers in Family Planning Association of India. Intrauterine growth restriction, when to deliver. MOGS manual on labor room protocol. Optimizing obstetric outcome after repeated pregnancy loss. FOXY, focus on recurrent pregnancy loss. Rational use of drugs, book by Family Planning Association of India on drug use at primary healthcare level. Once again, welcome Dr. Chopra. Over the session to you.
Hello, thank you so much, first and foremost, for inviting me for this talk. I'm really honored and happy Dhanteras to everyone who is celebrating today. On this auspicious day, I'm talking about Carbetocin, which is a very important molecule in nowadays in obstetrics. And I'll explain to you why it is important and how we use it in our labor rooms. So I'll start with our talk. I have been introduced. So now my experience with Carbetocin is the topic which is there today. And I feel that Carbetocin, being a newer molecule, is a boon for us obstetricians. And specifically, it is superior to other uterotonics. And I'll be explaining with respect to scientific studies regarding the same. So first, there's a case study. I'll be telling you a few case studies with respect to Carbetocin. So there was a 33-year-old, gravida 4, with previous 3 normal deliveries, and she had around 38 weeks gestation, came with pain in abdomen, that is contractions, and leaking PV since 2 hours. She was vitally stable, afebrile, uterus was full term, and the baby's head was floating, and the cervical os was 8 centimeter dilated. Though she was 8 centimeters, the station also was +2, Liker was clear. And patient progressed normally, and she delivered vaginally a baby of 2.7 kilos. And placenta and membranes were expelled completely, and she was given Carbetocin prophylactically. There was no PPH. The patient was stable post-delivery, and she was discharged on the 3rd day post-delivery. She was lactating. Baby was also fine, comfortable. Episiotomy wound healed very well. So in this case, we only used Carbetocin and no other uterotonics were used, and patient was completely fine. In the second case, woman was 28 years old with 38 weeks pregnancy. She was a gravida 3. She had previous 2 miscarriages, and she had been started on platelet inhibitors. That is, we started her on an aspirin 150 milligrams. That's because she had an ANA positive weekly. That could be the cause of her previous 2 miscarriages. Also, some protein powders were started to her from the 2nd trimester, and labetalol was started because she had been detected with pregnancy-induced hypertension. The USG for all trimesters were normal. Touchwood, she did not have any growth restriction. And she was induced at 38 weeks by the swiping of membranes, and she was monitored. Her BP was monitored because she was a patient of PIH. ARM was done at 3 centimeters, and an oxytocin drip was given, and magnesium sulfate was given for prevention of eclampsia. There was a continuous fetal monitoring, the labor monitoring was done, and there was a full-term outlet forceps was given to the patient to shorten the third stage of labor. And the vaginal birth was, the baby was around 2.7 kilos, and baby had a good Apgar score. Sorry, second stage of labor. And prophylactically, IV carbetocin was given, and she had no PPH. Pitocin was given because magnesium sulfate was also being added to her treatment protocol to prevent eclampsia. So in this case, we used the forceps. So we had to give IV carbetocin, and basically she did not have any extra bleeding, no hemorrhage was noted, and we gave her a nice 2.7 kilo baby and with a good APGAR score. So this was a good, well-managed case. The third case was patient had a twin pregnancy, and she came at around 36 weeks. She had a scan showing that one baby was in breech, one was vertex. Now, technically, this patient was posted for a cesarean section. The os was 3 centimeters and 40% effaced, and the first twin which was presenting was breech presentation. It was a little precious pregnancy also for us. So we delivered the female and male baby, another 2 female babies of around 2 kilos, and placenta and membranes were delivered completely. But still, because of the twin pregnancy, the uterus was atonic. The uterus was very dilated. It was atonic, and the bleeding was not being controlled. The uterus kept on becoming soft, and the bleeding was taking place. So we had to give her oxytocin, 10 units intramuscular, and then IV infusion was also started. The uterine tone was not regained, and Beelan sutures were then taken. But we gave even carbetocin slowly IV, and then the bleeding was controlled and patient was stable. So in this case, yes, there was atonic PPH that occurred. We did not have to progress to an obstetric hysterectomy. We gave our carbetocin and also took Beelan sutures. So these are these 3 cases which were presented in which we have used carbetocin. So let us take an overview of a dreaded complication in postpartum hemorrhage. Postpartum hemorrhage can occur in any case. We have to be more careful in certain high-risk cases, but it can occur in any case. So postpartum hemorrhage, let's start. So a normal postpartum patient, there will be a contracted uterus. The endometrial lining will be thin. The uterus will be bulky, of course, postpartum, but there will be no clots inside, and there'll be no hematomas. There will be no collections, pelvic collections outside, and no broad ligament hematomas is what I mean. In atonic PPH, the endometrial cavity is dilated. You can actually see blood within the uterine cavity. The uterus has not contracted well. It is very bulky. Involution has not taken place. So this is a patient with has got atonic PPH. So PPH is a loss of at least 500 ml of blood following a vaginal birth and 1000 ml after a cesarean section. PPH is common and can occur in any woman. I feel that this is a statement which is made to all of us at the beginning of our obstetric careers, that PPH can occur to anyone, and it's a nightmare for all of us. PPH is the leading cause of maternal mortality in low-income countries and is a primary cause of nearly 1/4, that is 25% of all deaths maternal deaths, which are globally. I recently, around 3 weeks ago, had a case. She was a Gravida 4, Para 2 living 2, and a previous miscarriage at 38 weeks. So Gravida 4 means uterus and a previous stillbirth the baby had had. So this patient needed, and she's a Rh negative patient with a Coombs test positive, quite complicated case. And she, after the cesarean section, did have a mild atonic PPH. The 24 hours that we went through with that patient, me, my assistants, the residents, it's something that I will not forget. Patient is stable now at home, around a month now, but it was something which I will always remember. Postpartum hemorrhage is very unfortunate, but it is very common still. It is the leading cause of maternal mortality, accounting for about 25 to 35% of all maternal deaths. In developing countries, the maternal mortality was 240 per 100,000 live births compared to 16 in developed countries. So in developing countries, it is very much higher compared to developed countries. And the global incidence is around 14 million women suffer from PPH. And the incidence is around 2 to 4% after vaginal, and it is higher in a cesarean delivery. PPH incidence in India, 38% of maternal deaths are due to PPH, and around 26% of global deaths take place in India. And two-thirds of these are attributed only to PPH. So India has a very high rate of maternal death, and especially due to PPH. So this is something that is really a good take home for us, that PPH, and anyways in India, the maternal mortality is high. And because of PPH, PPH is a major causative factor of the same. So what is the etiology? This is what we have been taught in our residency, the 4Ts, that tone, thrombin, trauma, and tissue. So tone, we always check whether the uterus tone is contracted. So the atony is a very important cause of PPH, and uterine tone is more, means if the more dilated the uterus at the time of pregnancy. So if the patient has a twin or triplet, multiple pregnancy, if she has polyhydramnios or a multiparous woman, the uterine tone generally tends to be a little more softer, and such patients can go into PPH. Thrombin, any patient of coagulopathies, low platelet count, or basically these patients are more prone to having clotting disorders. So the blood doesn't clot normally in such patients, and such patients can undergo PPH. Trauma to the uterine tract, that is injury to the birth canal, rupture of any of the arteries, or rupture of the uterus, uterine inversion, lacerations, all of this trauma to the genital tract can cause postpartum hemorrhage. And tissue, retention of placenta, retention of clots, abnormally adherent placenta, all of this can also cause postpartum hemorrhage. Clinical findings. So basically, the patient will give us the most important clinical finding, that is, there'll be abdominal tenderness, there'll be a high pulse rate, circulatory collapse, the abdominal girth will go on increasing, the uterine contractions, the uterus feels very soft, and there is vaginal bleeding. So there's a degree of shock that we see in the patients. The severe shock is something which we don't want to ever encounter in our life. So there's a compensation that takes place first, that around 500 to 1000 ml of blood loss, that is 15%. There is no change in blood pressure. The patient has little tachycardia, palpitations, and dizziness. Mild shock is around 1000 to 1500 ml. There's a slight fall in the blood pressure. The patient has sweating and tachycardia. We call that look of a patient a patient looks a little toxic to us. There's a typical look in the patient. She looks a little pale. There's sweating around her lips. And you just have to see the patient to know it. Moderate PPH is around 1500 to 2000 ml of blood loss. There's a marked fall in the blood pressure. Patient has pallor. The urine output starts decreasing. That also we monitor. And there's a lot of restlessness. And of course, in the maternal collapse, the patient has air hunger. The urine output is completely zero. And there's a profound fall in the blood pressure, and tachycardia is also very high. So this is the stages of shock which occurs in postpartum hemorrhage. Diagnosing. So first is the initial evaluation. We obviously check the vitals of the patient. We check what is her pulse, her blood pressure, the SpO2, and just an assessment of her status. So then I will obviously see her stomach, palpate her abdomen, see for the height of the uterine fundus, whether it feels soft, see the amount of vaginal bleeding, save all pads. We will avoid repeated pelvic examinations, but if we suspect there's a genital tract trauma, then of course we have to place the patient in the lithotomy position, check the cervix, check for vaginal lacerations, check for hematomas, check for inversion of the uterus. Also to check, we sometimes get a sonography machine to check if there are any retained blood clots, any retained placental tissue, amniotic membranes, which are there inside. And we check for the uterus if there's a uterine inversion. Sometimes in multiparous women, uterine inversion also takes place. And then, of course, at the same time, I will be sending a complete blood count to check for the hemoglobin, the hematocrit. Hematocrit actually gives us a very good idea of the blood loss, and platelets. Coagulation studies are done so that we see that the patient is not going into DIC, urine output is measured, and of course, TPR, BP charting, and saving all pads. I obviously tell them to save all pads and not throw away, so that we have a visual assessment of how much blood loss has taken place. Approach for the tonicity, abdominal palpation that I said, we feel the uterine fundus. We send a CBC, coag profile, LFT, RFT, and an abdominal ultrasound is done. We will obviously start with uterotonic agents, that is prostaglandins, oxytocics, and ergot alkaloids. Sometimes a balloon tamponade we can be used, and the hemostasis algorithm. All of us have in our labor rooms, we have a pre-pH protocol, which is set up in all labor rooms, and we have a protocol, call for help, take two large bore IV lines, send blood group cross matching. All of this has been kept. There's a protocol, a hemorrhage protocol, which we follow. Then, of course, for the trauma, we will do an entire examination if there's been a vaginal delivery, a sonography assessment. We will, of course, check if there's been an extension of the angles at the time of cesarean section. We remove the uterus, check there's no broad ligament hematoma. And extragenital causes such as subcapsular rupture of ovarian or splenic vessels can also happen. Ultrasound is really valuable in a center, in a tertiary level center. Ultrasound gives us a picture that whether there is any collection, pelvic collection, or there is any intrauterine collection. And also some centers have got uterine artery embolization. It's a very new technique. It is especially useful in broad ligament hematomas or supralevator hematomas. Sometimes we use PPH for atonic PPH also. Doctors are now using. I have had a few senior doctors tell me that they use this for use the uterine artery embolization, and it has saved certain lives. Of course, retained placenta and membranes can also be. We have to see whether do a sonography to see. We even can do a bimanual examination and just check if there's any retained clots. We have to do an examination under anesthesia and then have a manual removal of the placenta. Coagulopathy, of course, if there's a continuous bleeding, but the uterus is contracted. So we, of course, send urea, electrolytes, CBC, and a coag profile. And we have to give an immediate replacement of the blood. Sometimes FFPs are factor 7. Recombinant factor 7 is also used. Platelets are used. So it's like a whole, the blood bank needs to be present inside the hospital. That's why PPH subjectively should be managed in a tertiary level center. And of course, at the last stage, we can go for a surgical remedy, that is an obstetric hysterectomy or a Beelan suturing, to save such a patient. Attempts have to definitely be made between the 40s to identify what is the cause of the PPH. Sometimes it's just the patient profile. So now, what was the need for developing a new heat-stable formulation of carbetocin? Because oxytocin and other ergot alkaloids needed to be kept in a certain refrigerated temperature, and previous formulation of our carbetocin needed to be stored between 2 to 8 degrees. And heat-stable formulation of oxytocin is still not available. But resource-poor countries like us, every place we cannot have a refrigerator facility to store these ergot alkaloids and certain oxytocic compounds in refrigeration. So why carbetocin is good? It is stable at room temperature. It has a shelf life of around 2 years and at 30 degrees, and it survives 75% humidity, which is really good for Mumbai weather. And it avoids the need for cold chain storage, and it is provided in a vial. So what is the use? When do we use uterotonic agents? At the crowning of baby's head, at the delivery of anterior shoulder, at the end of second stage of labor, and following the delivery of placenta. Prophylactic use is, of course, used for the prevention of PPH and the active management of third stage of labor and management of PPH. So what are the molecules? Oxytocin, carbetocin, ergometrin, syntometrin, and misoprostol are all of these molecules that can be used in the management of postpartum hemorrhage and as to maintain the tone of the uterus after delivery. Technically, when I was in my Palaghar posting for my internship, we used to just use oxytocin if that was available, or probably a misoprost. Sometimes the uterus would contract on its own. But it has been shown by studies which I read that 40% of PPH can be prevented by using oxytocic agents or certain uterotonic agents. So I think these agents are a boon in modern obstetrics. What is the carbetocin? Was created making modifications to the oxytocin structure. So this is the oxytocin structure. And there is an addition, modification of the molecule of oxytocin. So it prolongs the half-life of oxytocin, and it reduces the degradation of the molecule within the body. So it's a synthetic long-acting analog. It prevents postpartum hemorrhage, and one vial contains around 100 micrograms, and 1 ml solution injection is given to the patient. So the clinical evidence, there's a lot of clinical evidence of efficacy and safety of carbetocin versus oxytocin. So there's a WHO champion trial, and I'll be going over it in the next section. So what is the champion trial? That is the carbetocin hemorrhage prevention. It's the largest clinical trial in the prevention of PPH. So the study design was to non-inferiority, double-blind, and a randomized trial. And the objective of the trial was to compare the effectiveness and safety of heat-stable carbetocin to oxytocin. And around 30,000 women across 10 countries, our country was included in this. And the primary outcomes that were measured were the proportion of women with blood loss of at least 500 ml and or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1,000 ml. And the trial was conducted by the WHO Department of Reproductive Health and Research. The parameter which was measured, so the non-inferiority was established. All right, so the efficacy was relatively similar of carbetocin and oxytocin. The blood loss also reported of carbetocin and oxytocin was comparable. Safety was comparable. So basically, the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior. And the use of additional uterotonic agents to block or to prevent bleeding and the adverse effect did not significantly differ. So it showed that they both were comparable. It was non-inferior, and it was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml. So it showed that it is comparable. The guideline recommendations of various societies all over the world, WHO says that only one of the following needs to be used, which are the oxytocin, carbetocin, misoprostol. The SOGC, that is Society of Obstetricians and Gynecologists of Canada, says carbetocin has to be given in 100 micrograms IV bolus. Then the Society for the Reproductive Health of Australia and New Zealand in 2017 has said that the active management of third stage of labor says that you need to use uterotonics. FIGO, carbetocin, one of the recommendations for PPH management. Germany, Austria, Swiss, all of them recommend the use of 100 micrograms of IV carbetocin. And France, FCOG, says carbetocin on proving non-inferiority to oxytocin. So most of the societies all over the world recommend the use of this molecule to prevent PPH and for prophylaxis of PPH. The key messages: so postpartum hemorrhage remains a significant cause of maternal mortality, maternal complications, and morbidity worldwide. It is common and can occur in any woman. There is no risk factor, or even if the patient is a preemie and has nothing, she can still get into PPH. So we need to have an active watch for such a patient. PPH has a major impact on the lives and health of the affected families, because sometimes the mothers incur a lot of blood loss, they have a lot of morbidity, they're not able to take care of the baby after delivery. Maternal mortality is also increased by PPH. WHO recommends the use of prophylactic uterotonic as an important step in the active management in the third stage of labor. This could reduce the risk of PPH by more than 40%. Carbetocin is a synthetic, long-acting analog of oxytocin, and it has been made by the modifications of the oxytocin molecule. It is now available in a room temperature stable formulation, and it is there in a vial. It's present, its formulation can be provided in a vial. It has a similar efficacy and safety profile as oxytocin. And additionally, it reduces the need for additional uterotonics and for uterine massage. And it reduces the blood loss for less than 500 ml in most women. So champion trial, where the women, around 30,000 women were included in the study, inferred that carbetocin was non-inferior to oxytocin, and it prevented the blood loss of less than 500 ml, and prevented the use of additional uterotonic agents. And compared with symptometrin and misoprostol plus oxytocin, carbetocin demonstrates a better hemoglobin level and lower risk of hypertension and other adverse events. So cardiovascularly, it is much more, it is better. It makes the patient more stable. And the WHO, FCOG, FIGO, SOGC, RANSCOG, and they all recommend the use of carbetocin in the management of PPH. So that's all for me today. Yes, Dr. Prashant.
Thank you so much, madam. Just one question first before you go to panel question. You mentioned Palghar. You mentioned Palghar in your
Yes. I had gone to Palghar for my like government rotation.
you are part of a GMC. You are a
Yes,
GMC.
I'm part of Grant Medical College. Yes.
No, this question came first because even I am a GM side.
Oh, that's so nice. Yes, I was in Palghar and we have done
Yeah, yeah.
deliveries
Even I
in
was in Palghar.
without electricity, and in that Palghar PHC, I remember it used to be the episiotomy stitches. One would hold a torch on our mobile and we would take the stitches.
I'm
And
surprised the facilities have not changed, huh? Because the same thing we experienced in late 70s.
yeah, no, this was my right now in 2000. But I mean, for me, I just feel things change, but we have such horror stories also. But the advent of these uterotonic agents are very nice. So I that flashes in my head because there was a patient who had a hematoma, a huge pelvic hematoma, and we couldn't manage her there. So I remember I sat in the ambulance and I took her to the B. I think
Yes,
there was
yes,
a B say I don't know remember Boisar ka hospital. They used to be
yes,
close
yes,
by. So we had to
yes.
take her to over there.
Anyway, we're coming to the questions.
Yes.
Can you move the
Yeah.
slides, madam?
Yeah.
First of all, what is your experience on using carbetocin? Like, you have said that it is, have you seen any failures with carbetocin?
Yes, there have been. Like I have had one or two cases. See, now mostly we are all shifted. All my colleagues, my seniors, we've all shifted to using carbetocin.
Correct, correct, correct.
And so, yes, but there have been one or two cases where there has been failure of the use of carbetocin. But those patients had additional risk factors, like they were twin pregnancies, they had, pregnancy-induced hypertension. But still, the uterus was a little more atonic. And I think in my recent two patients I had who carbetocin did not really work. So we had to push an IV, bolus of I use pitocin also, and then I gave methergin also, all of it, and the patient is stabilized. But yes, two cases of mine, there was a failure of carbetocin. But overall, I think it is a molecule which is very useful because after I use carbetocin, I do not need to use anything else.
And as you rightly said, expect the unexpected is the thing in gynecology. So you never know which patient will finally land in.
Yeah,
Yeah.
yeah, exactly.
Next question, can we go to?
Yeah, next question. One minute, just hold on.
Is there any specific patient profile where the doctors can anticipate PPH?
So see, like we said, you mentioned just now, there is no patient profile. Any patient can have PPH.
Absolutely.
But there are few risk factors for the patients. I have seen the patients who are anemic, do have a predisposition to having PPH. Patients with PIH, diabetes, twin pregnancy, multi-gravid women. And I think in India, Indian women are more prone to having PPH. When I was in UK, I had a minor, I had 1.5 year where I worked for the NHS. Over there, they used to say that African American population have a slightly higher tendency. So mainly the ethnic races, we have a slightly higher tendency to having PPH. So I think racial factors are also important, and they are included in our textbooks also. So we do pay attention to that. Yes.
Can calcium deficiency lead to PPH?
Yes, it
Case
does.
of
It does.
ultrasound not
So
released.
basically, now they even suggest to give good calcium supplementation for
Correct, correct,
patients
correct.
for prevention of PPH. I think it has to do with the muscle
Okay, yeah,
contractility, the
muscle
smooth
contract.
muscle
Yes, yes,
contractility.
yes. And post-date ladies, would they be more prone for PPH?
Yes, that's because of the uterus getting more dilated. And
Right.
somewhere I think there's a hypothalamus pituitary axis maybe which is
Correct,
not
correct,
working.
correct, correct.
So, that's why they have gone into the postdatism. The delivery is induced by the HPO axis and the secretion of certain hormones by the fetal adrenal glands. So some studies, I'm not saying this is proven, they have said, yes, because of that deficiency, there is a small lack of production of innate oxytocin by these women, which can cause the patient to have PPH.
Maybe go to next question.
Yes.
When would you prefer carbetocin or oxytocin for prevention of PPH?
Now, in cesarean deliveries, I prefer to use a carbetocin. Also in vaginal births, which have risk factors such as a patient who's multigravid, PIH, diabetic, polyhydramnios. And when you need a longer action, because the duration of action is also longer, the half life is longer, and it onset of action is also quicker. And also in patients who have used oxytocin for induction of labor, I think I use carbetocin for the prevention of PPH in those patients.
Right.
So we use a ripening drip, right, of oxytocin for ripening of the cervix for induction. So in those patients, I prefer to use carbetocin for prevention.
Next question can we go to?
Yes, sure. Yes, we can use carbetocin for the prevention of retained placenta. So sometimes when you suspect, so retained placenta is defined by the placenta is not separated at after 30 minutes, after the delivery of the fetus. And such cases, see, of course, if we rule out the morbidly adherent placenta, nowadays with the advent of sonography, we rule out all this abnormal placentation. But in case of a normal adherent, normal placenta, if it is not separated, sometimes I have seen one or two seniors, they have injected this into the umbilical vein, and it causes the myometrial contractions, and it aids in the separation of the placenta from the uterine bed, and it helps in the delivery, prevents the blood loss. So carbetocin can be used for the retained case of placenta, obviously, but we do have to take care at that time. The anesthetist has to be told to relax the patient a little bit, because sometimes after the use of excessive oxytocin, patients do experience even the smooth muscle contraction of the heart. They do get anginal pain. So that time the anesthetist is very useful.
And also has to be open, of course, finally.
Yes.
Next question.
Yes. I have used recently in the patient, a multigravid patient of mine. She was already ICT positive. So, I used carbetocin in that patient because she had atonic PPH even on table. So I use the patient and then I give them the anti-D later on. Though obviously we cannot use methyl ergometrin and all, but we do use, we obviously consider the patient's life more important.
Yes. In Mumbai, we may not have difficulty, but in the interiors, there may be a problem if the lady lands up and blood transfusion RH negative. All this could be an issue.
Yes. But in Mumbai, we don't have so much of an issue. But we do give anti-D. I think now anti-D giving of all RH negative women is done anywhere. I don't know. I think even government hospitals are excellent. We do give anti-D to all RH negative mothers. So there's nothing to worry about that. Yeah. And a doctor use carbetocin for the prevention. Yes, I just said no. If carbetocin has been used, so yeah, I use it. But in these cases now, I may have to top up on giving a methergin or a misoprostol or a carboprost, depending. It depends, because if you used it for the induction of labor, you may need a little more dose of uterotonic. But most cases, carbetocin is enough. In which cases would you prefer IV route? So now they say IM route has a more prolonged action. Okay, studies, though there is no study telling the efficacy of one route over the other. I have only used IV. IM to मैंने नहीं use किया है. But on reading, I realized that IM route has a more prolonged action, whereas IV route has a quicker action. And if you want a quicker action, the IV route, if you want to have a more prolonged effect of carbetocin within the blood, which is around 2 hours or 3 hours, you use the IM. Yeah. Next,
use the IV route.
Yeah, more rapid. Most I have used IV only. 100 microgram IV given slowly over 1 minute. If a patient is not responding adequately with carbetocin, what would be the additional uterotonics? Methergin,
Okay.
I mean, misoprostol, carboprost, all of this can be used. Symptometrin.
Everything
So,
is at a
I
very
mean,
simple effect.
it's a stepwise. See, every labor room has their protocol, you know. So, we have printed in all the labor rooms that I have gone, there's a printed protocol on the wall. Okay. In case of PPH, use this. So, yeah.
The use of Methergine maybe or a Carboprost maybe or
Yes.
depending on the
First
protocol.
Methergine, then Carbopro. First they'll say IV bolus of oxytocins. If that is not there, then Methergines, then Carboprost, then uterine massage, balloon tamponade, then, you know, so all of it is a stepwise PPH protocol that we have. What are the advantages of carbetocin over oxytocin? So obviously the half life is longer. It is more heat stable in compared to oxytocin. All right. So 40 minutes is the half life. It is around 4 to 10 times more than that of oxytocin. It lasts also longer. The efficacy, the period duration of action is longer, and it is can be used in the post-operative hemoglobin drop is less in carbetocin as compared to other utrotonics, and the blood loss is lesser. So this is the preference of oxytocin. Misoprostol and carboprost and methyl ogometrin all have certain side effects, systemic side effects over the patient's body. So with misoprostol, there's a rise in temperature, shivering. Patient can have gastric upset, lose motions. All of it is avoided with with carbetocin. Similarly, with carboprost, patient feels nausea, vomiting, gastrointestinal side effects. Methyl ergometrin can cause rise in blood pressure, contraindicated in anti in Rh negative patients. So in such cases, I can use carbetocin. And but carbetocin, there has to be a caution in the use in patients of kidney, liver, and heart disease. It has to be used with caution. And in a proven case who has had allergic reactions to oxytocin, you do not use carbetocin. And one more effect of carbetocin, which is superior to that of oxytocin, is it doesn't cause the antidiuretic hormone side effect. So the effect on the urine output is lesser with use of carbetocin. So we are very confused that why is the patient's urine output lesser after we are using these utrotonics? But that is something which will not be seen if we use carbetocin.
With ADA, there's sometimes water retention also. Oh, sorry, with oxytocin, sometimes there's water retention.
Yes.
And one of the most important thing, maybe not be in Mumbai or maybe in the interiors, that doesn't require a cold chain.
Yes, I said that. It's a temperature stable, room temperature stable. So you do not require cold chain. Yes.
Next question.
And last, should carbetocin be kept as a reserve drug? No, I think that reserve drug now it is the first line. We use it as a first time. I mean, the anesthetist asks me also before we are preparing and printing and draping the patient. Only they ask me, you want pitocin or carbetocin? So I'm like carbetocin. You know, they when we are painting the patient, only they ask you this question because then they keep everything ready. You know, so that is the thing. So it is the first line of drug. It can be used as a reserve, but I would say that now it is more coming towards the first line. And how would you compare adverse side effects, contraindications? I think I mentioned this, right? Basis hemodynamic profiles. So I think in a patient who is cardiovascularly compromised, we do not give so much of oxytocin. Carbetocin can still be used, but if the patient is having renal failure, hepatic failure, we use it with little bit of caution. Any oxytocic you use with caution. And that's it. That's anything else you wanted to add?
No. I mean, most of these questions are answered in the talk, but just to summarize.
Exactly. We just mentioned all of it.
This would be the last question, the next one.
I think, how would you conclude efficacy, safety, and tolerability of carbetocin?
In short, one line on your take on carbetocin.
One line. Carbetocin is the first line drug in most labor practices, and efficacy, safety, and tolerability. I find that line in that trial very weird. Okay? It is non-inferior. Why would you use non-inferior? Because they don't want to use superior. I think. So, but I don't think it is superior. But I feel carbetocin now will come up as a very one of the first line drugs in the management of PPH. comparable to oxytocin once it is made available in low resource settings. So I think misoprostol is very easily available. Actually, every place they have misoprost because it's cost effective and it is room temperature stable. It has a longer shelf life, you know. So I think misoprostol, that's why they are using more. But the mode of action, like the action takes place it takes a long time to act. Misoprostol effect is not very immediate as much as carbetocin. So
Risk in PPH. I think that is all, I suppose. Thank you so much, madam. It was a lovely session. You gave a lot of insights, your own insights. Lovely it was. Thanks once again.
thank you so much for inviting me today. Thank you to the entire team of Carbiact and Carbetocin. And I am very, 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 very happy that you have invited me today. Thank you to Hetero. And wishing everyone a very happy Diwali in advance. And today, happy Dhanteras. May this Diwali light up everyone's lives and bring a lot of blessings and good wishes to everyone. Thank you so much.
The participants who have taken time from their busy schedule and attended this. Thank you, marketing team Hitro, for conceptualizing and making it possible. Thank you, field people of Hitro, for actually implementing this. Last but not the least, thanks IT team for your IT support in all the matters. I'm wishing all of you happy Diwali once again, and thank you. Signing off for the afternoon. Thank you once again.
Thank you so much. Thank you.
Thank you, ma'am.
Thank you so much. Thank you for the invitation.
Yes, it was such a wonderful session, ma'am.
Thank you.
Thank you.